Good morning. Welcome to Modernizing America's Care for Better Health. My name is Jacob Schiff, and I'm Chief AI and Technology Officer at the CMS Innovation Center, where I focus on policy to enable the effective adoption of technology by providers, payers, and patients. Thank you for coming today and tuning in virtually. We have an amazing lineup of speakers this morning from across Health and Human Services, as well as from a few outside of it. We'll jump right into it. I'm thrilled to introduce as our first speaker a leader from across the administration, and in particular within CMS and HHS, Amy Gleason.
Hello, good morning. I'm thrilled to be here today to celebrate the launch of the Access Model. Today is a big day for innovation, for care transformation, and most importantly, for patients. In July, we announced the CMS Health Tech ecosystem at the White House. It was a different kind of initiative, not one through regulation that brings change over years, but one that's a voluntary effort meant to drive change quickly, in fact, just in months. As a recap, there were a few main pieces of the Health Tech ecosystem announcement. And at that announcement, we foreshadowed some new events, and that's really the Access Model is the beginning of that. So first, we wanted to fix interoperability once and for all. So after many years of regulation, interoperability should work on paper, but the reality is it's still too hard for providers and patients to get the information that they need. The Health Tech ecosystem that we launched created a CMS interoperability framework as a vision and framework to find solutions to these challenges. This framework puts patients front and center and aims to solve some of the stickiest challenges, especially around trust. As part of that effort, CMS announced its part of building some infrastructure pieces to help with that trust. A national provider directory that helps apps and technology figure out where to find the data that they need, and modern digital identity so that we can trust that the person asking for the information is who they say they are. And although the interoperability infrastructure is important for a lot of reasons, the main goal for that was really to help empower patients. We want to give them modern technology, like the things they have in other parts of their lives, and give them personalized care that can support them in any hour of the day, anywhere that they are, through the apps that they choose. The burden to get health information has been way too high for patients for too long. As an example, my daughter has 47 patient portals. That's virtually impossible for a single person to manage. And so this app ecosystem that we're building really helps patients with one click through an app of their choosing get all of their health information without having to remember portal logins or the doctors that they've seen in the past. So we started with three main initiatives as use cases. The first one is Kill the Clipboard, which enables patients to use an app they choose to have their records and to scan a QR code or tap a smart health card when they go see their provider to share their information immediately. And then once they have that information, to be able to use conversational AI to give them personalized advice and recommendations. And then lastly, straight up the Maha lane, diabetes and obesity prevention and management. Those can all be personalized if we have their health information as well. So we began with 60 brave companies who raised their hand to stop saying, we can't do this because, and to find ways that we could say, yes, we can. These companies pledged in categories such as patient-facing apps, EHRs, or electronic health records, providers, payers, and data sharing networks that will respond to queries from patients, providers, and payers. And since then, the momentum has been incredible. We have over 400 companies that have pledged their support to meet these goals by the end of the first quarter in 2026. We've added a new category because we've had so much outreach from people called the Friends of the Ecosystem. These are people and companies that want to participate. They can't meet a whole pledge category by themselves, but they want to be part of the solution. This entire effort is fully voluntary, yet the excitement is palpable. We have 13 technical working groups that are all led by volunteers who stepped up to lead in finding solutions to these challenges. And we have representatives from hundreds of companies working shoulder by shoulder, not competing with each other, but collaborating on solutions. So CMS didn't dictate answers in this case. We challenged the industry to prove what's possible, and you all are doing it. On November 13th, right in this room, we had over 180 companies, many of them competitors, who came together and demonstrated real progress. Patient-facing apps pulled clinical records from CMS-aligned networks based on the patient's request, and then delivered personalized guidance back to the patient. These same apps shared relevant data back to the provider's EMR through the patient's choosing. Payers showed real progress of reducing administrative burden, like letting providers request a digital insurance card using a few demographic fields. CMS released its first provider directory sandbox and is working collaboratively with the private sector on accuracy and better interoperable data. And CMS reaffirmed that it will add modern identity to Medicare.gov and that Medicare will respond to requests from patients and providers for claims data. So the momentum is strong, the technology is real. The ecosystem is proving that right now this is possible. But there's been one thing missing: a payment mechanism that supports technology-enabled care and the providers who use it. We needed a way for technology-enabled innovation to get paid for driving outcomes, for providers to get paid for referring patients to these tools and for monitoring and addressing their care plans. That is why we are so excited about the Access model. Access is going to supercharge the CMS health tech ecosystem and healthcare everywhere. It rewards outcomes, it encourages continuous engagement instead of reactive care, and it supports a future where innovative apps, trusted relationships, and real-time personal support are part of how they deliver care today. Access gives us a way to scale it, reward it, and make it real for millions of patients. If you haven't yet pledged to join us in the ecosystem, we would love to have you go to the CMS Health Ecosystem page, and you can pledge in any of those categories. We look forward to collaborating and can't wait to see your success.
Thank you, Amy. Next up, we have a man who needs no introduction, CMS Administrator Dr. Mehmet Oz.
Thank you, Jacob. And Geeta, who you'll hear about in a second. Where's Geeta? She's a flight risk. There she is, Geeta. And Abe Sutton, who is not here today because he had a baby 2 days ago. And his son is doing wonderfully well. He's already teaching him words. I could see it happening. But if you knew Abe Sutton, and many of you do, you'll appreciate what a blessing it is for him to be able to bring another child into this existence. I was asked yesterday about some new data that had come out on growth rates of healthcare expenses in this country, and it's around 8% predicted growth rates. There's some places, commercial insurance is increasing at around 9% next year predicted. And that is more than twice the growth of the GDP. And the question I was asked is, what are you going to do about it? And we can focus on lots of ideas, and we have many of them, but it fundamentally comes down to our ability to empower patients with better information and incentivize providers to use that now empowered patient in order to make, they're clearly the biggest stakeholder, make them the one actually driving the economic engine of the system. So much of what this administration is trying to do by putting information and transparency into the system will allow it to function more like a market, and we believe allow the health economy to grow at a rate similar to the GDP rather than at twice that rate. Because we risk becoming one massive healthcare system with a country attached to it. It's not healthy at any level, and I don't think it actually helps the health of the people we're trying to protect, because life expectancy continues to fall in America, and particularly in some areas, like in rural America, where life expectancy now is 2 to 3 years shorter than urban America. Much of the cause of this is because of lack of transparency, but also lack of data access and decision-making based on that information. That's what today is all about. I want to applaud Amy's work in creating an infrastructure for a tech transformation within our healthcare system. She's based at the White House, United Digital Service, at DOGE, at CMS. She's everywhere now because we need technology everywhere. But you have to reduce it to practice. At some level, you have to actually make it come alive so people can touch it, feel it, use it, and benefit from it. And that's what today's big announcement is really about. The CMI, the Innovation Center at CMS, is iconic in its ability to come up with new ideas. It's the nuclear reactor that actually has allowed so many concepts to be reduced to practice and therefore be available in communities around America. And Adam Bowler actually, I just don't know, so Adam actually ran CMI. When you have alumni coming back from prior administrations, realize how much power there is in this organization. But interestingly, people who run CMI tend to go off and really do very innovative things because the whole mindset is to go out there and make a difference. The access model is a shining tribute to this characteristic. It is going to bring Medicare into the 21st century. We're only 25 years late, but bring Medicare into the 21st century by increasing access to digital health services. And I want to spend a few moments of the morning speaking to some of the details of why this is so critical. For the first time, it's going to give beneficiaries of original Medicare and their providers access to high-value, technology-first, supportive care options that I think are going to make a massive difference, specifically preventing and managing chronic diseases and diseases that people tend to be a little bit reluctant to talk about, like mental health conditions. It's a program that will help patients. It's a win for them. It's a win for providers. It's a win for the American taxpayer. It's a win for America. And I want to make sure that you all know that the CMI program that put this together is uniquely responsible. They took months and months of hard work with a wonderful team that has grown quite dramatically under Abe Sutton's leadership and allowed us to today recognize something with full fruition. The team has been working hard at access for a bunch of reasons. One, we needed to be able to crack the code on a few elements of this process of the puzzle, because we knew there were too many people with chronic health conditions who could otherwise be left dealing with those problems the way they have historically been addressing them, which is either not doing it at all or putting together piecemeal programs. They need, want, and deserve these programs. They will now start to get them. As a clinician, I'm a heart surgeon, I use data all the time at every level. I see the numbers of the monitors. I can hear the boop, boop, boop is not good compared to beep, beep, beep. That the tone makes a difference. I mean, with tactile feedback, haptic feedback, across the board, we do our procedures using every one of our senses. Why would we not do similar things with the American people if they're struggling with diabetes or a condition that otherwise might be easily managed with continuous daily feedback and advice like what to eat or don't drink that or make the appointment or you forgot your insulin. All of these become tools to overcome barriers that have hindered folks, especially with chronic conditions, from benefiting from the digital world around us. Now, we've all seen digital health tools present in many ways. There's lots of great telehealth tools out there. There's software that's remarkable, AI systems that are offering avatars that are more believable than the real doctor who's in front of you, wearable devices, app-based coaching tools. They're all being widely used in the private sector, but they have not penetrated into original Medicare yet. And CMS does not have a path. We don't have a way to do it. That's why CMMI exists, to allow us to find a path for financing these options and to complement traditional care, high-quality clinical care with these additional tools. In response to this battle, we have created a 10-year voluntary model that's designated to provide Medicare with an on-ramp for digital health and digital therapeutic solutions that providers can now use and get reimbursed for. And right now, they don't have an option anyway, so any option's better, but this is a pretty top-notch solution that has come forward that's going to be able to help providers treat Medicare beneficiaries. The access model specifically introduces an outcome-aligned payment option to support high-value technology-enabled care that rewards results. We didn't want to pay for churn. We didn't want to pay for the use of the app. The fact that you're trying it out doesn't matter to us. We want to know, do the outcomes, clinical outcomes, vary? Because if they do, we think it's worth paying more for it. And we want to pay enough money that this becomes an interesting business opportunity for sponsors all around the world. And I say that with a great desire to highlight that we want people to make money building these solutions. That we're open for business. We want you to be open for business. We want you to come to us with ideas. And because it's an attractive option, we want innovative people to be able to build companies without having to giving it all away because it's such a high-risk endeavor. But we want outcomes. We don't want engagement. And the outcomes themselves will speak, like most other clinical interventions, to the way CMS does its math. Can OACT, our actuarial group, actually show that we'll be saving money for the American taxpayer, and for that reason offer higher and higher rewards to people who are able to reduce A1Cs or whatever endpoint we decide to use. It's going to give clinicians and patients new options, especially if they're in parts of the country where we don't have enough providers. And I mentioned rural health care. We've got the $50 billion Rural Health Transformation Fund that Emily Chen, who's in the back here somewhere, wrote the notice of funding opportunity for. These programs are going to work because states can now begin to use this massive bolus of cash to begin to use tools and apps that we think will be transformative. The access model sets the right incentives so we're technology forward in much of our ideas, use technology to increase access, and most importantly, we believe actually provide such great value that it reduce the overall tax bill for the American people. At its crux, this technology is about expanding technology and the role that it plays by empowering people, expanding access, and increasing choice. And that's what access has always been about. It's what it will always be about. And you're at the tip of the spear for making that happen. So God bless you for making time, and I look forward to the speakers who come after me. Jacob, who's a superstar in his own right.
Thank you, Dr. Oz. Next up, we have the honor of hearing from someone with unparalleled experience at the unique intersection of healthcare, technology, and public service. We really couldn't ask for someone better to speak on the subject of modernizing care. It's my pleasure to introduce Deputy Secretary of Health and Human Services, Jim O'Neill.
Thank you so much, Jacob. Thank you for having me. Everyone, good morning. Welcome to HHS. AI is advancing more rapidly than any technology we've seen in a long time, transforming how we work and how we live, accelerating discovery, and opening possibilities that are ripped from science fiction. But even as America leads the world in innovation, we continue to face a stark and urgent reality. The cost of healthcare remains unsustainably high, straining families, straining providers, straining our entire society. And despite all this spending, we have poor incentives, we have a broken industry, and we have poor nutrition, and all these things continue to drag our health downward. But we are changing this trajectory. In most industries, innovation, including AI, are providing benefits every day in most areas of life for most Americans. Our computers are better and faster and cheaper. Our telecommunications are better and faster and cheaper. But our healthcare so far isn't. But AI offers us an opportunity, along with other reforms that we're doing, to reshape the healthcare industry and make it part of the solution. At HHS, we're all in on AI. We're committed to leading, not following, and unlocking AI's deflationary, quality-enhancing potential. And we've already taken several important steps. In September, I made a custom version of an LLM available to all 65,000 employees here. And yesterday, I added a second competing model. We're the first federal department to take these steps. And we are improving the productivity of the people that work here. Today, we are launching the HHS AI Strategy 1.0, a roadmap for AI technology innovation throughout HHS, which will supercharge our own internal operations with an AI-empowered workforce and the best technology we have from AI. This will help us in the future accelerate approvals for new drugs and biologics at FDA, fight fraud and improve claim adjudication at CMS, and streamline grant reviews across the department. Looking beyond the internal applications within HHS, our vision for AI's role in healthcare is broad ambition and focused on real outcomes for patients and providers. We believe AI will enhance quality, expand access, and reduce costs, all while strengthening public health and safety. I'll mention three. First, we're exploring new reimbursement pathways that allow innovators to scale high-value technologies quickly and profitably. Payment for innovative care will determine whether it reaches patients and whether it improves outcomes while lowering costs. Without the right reimbursement structures, even the most promising tools will never achieve widespread adoption. The access model will help us build the evidence base we need to design a reimbursement framework for technology and AI in healthcare. Our announcement today marks the first step toward a more flexible payment system that rewards innovative health tech and improved patient outcomes. Second, we're committed to providing regulatory clarity so that developers are empowered to deliver safe, effective tools to patients and clinicians more quickly. Regulation should protect patients, but it should also enable innovation. At FDA, at the Office of National Coordinator for Health IT, and at CMS, we recognize that AI is evolving rapidly, and we need frameworks that keep pace with, rather than standing in the way of, innovation and access to this innovation. As a key pillar of our regulatory framework, we will ensure that payers, patients, and providers have full visibility into de-identified patient data. Not only will this help protect patients, it will enable a positive feedback loop in which real-time data drives continuous product improvement. Later this morning, you'll hear about Tempo, an exciting FDA initiative that will put innovative health tech solutions into patients' hands more quickly. Third, we're directing federal research and development dollars toward the biggest problems facing patients and providers, from early detection of illness to chronic disease management to reducing administrative burdens. The leaders gathered here today, healthcare and tech innovators from across America, represent the best of what this country can achieve when we work together. Baby Sutton will grow up healthy in an America benefiting from all of our work. HHS is committed to partnering with you to usher in a new era of innovation, to improve quality, reduce costs, and make America healthy again. Thank you.
Thank you, Deputy Secretary. Next, we'll hear from Gita Dio, who serves as Chief of Staff at the CMS Innovation Center, and will provide more context on the access model and how it fits into the broader Innovation Center strategy.
Thank you to the Deputy Secretary and Administrator Oz and Amy for all your support and leadership, and thank you to everyone here in the room and virtually that showed up to support the model. The CMS Innovation Center has a clear mandate. We test new ways of reimbursing and delivering care to improve patient outcomes while lowering healthcare costs. Our work is guided by 3 core pillars. First, to promote evidence-based prevention, helping people avoid disease where we can by enabling more upstream support and manage chronic conditions effectively when we can't. Second, to empower people to achieve their health goals so that patients are in the driver's seat of their own care, with data, tools, and care arrangements that fit and support their lives outside of the medical office visit. And finally, to drive choice and competition, so patients and clinicians have real options among high-quality organizations that are accountable for results. Underneath these pillars, we have a foundation of protecting the federal taxpayers by focusing on models that not only deliver better outcomes, but also have a credible path to savings. Access is a pivotal step that brings these 3 pillars to life to combat chronic conditions with technology-enabled care. Behavioral change, while critical to prevent or manage chronic conditions, is incredibly difficult, and that's a burden patients face every day today. While there has been tremendous technological growth to support patients in this journey, there has been a continued disconnect between what happens in the doctor's office and their day-to-day lives. Access is looking to change that through an outcomes-aligned payment approach, which will, for the first time, allow reimbursement for technology-enabled applications that lead to real results for patients. 2/3 of the Medicare population is impacted by one of the conditions that Access covers, and through this model, we are going to figure out which approaches work best for patients to take charge of their health. The goal is not a one-off experiment, but a model that can inform how technology-enabled care is paid for across the system. And so with that, I'm going to hand it back to Jacob to actually walk through some of the more details of the model for y'all.
All right, and now I will introduce myself. We're going to jump into it and give a little more details around the meat of the model. So if you'll indulge me, we'll spend about 10 minutes getting into some of those specifics. As the name implies, the model Access is focused on increasing patient and clinician access to effective technology-supported care options for chronic condition. We don't have to spend too much time talking about the problem. I think others have described that. We have a crisis in this country of chronic disease. Millions of Americans struggling with hypertension, depression, pain. We also have a clinician workforce that is overworked, overstretched. Modern technologies present a unique opportunity for us to empower patients and clinicians to really extend care beyond the clinic and ultimately help people live better lives. But as we've heard earlier, today's payment options really haven't caught up with that. And as a result, clinicians are constrained in how they can deliver care, patients are deprived of these options, and the system as a whole is worse off. And that's really where Access enters the scene. It introduces a new payment option, outcome-aligned payments, that emphasizes outcomes rather than activities and enables technology-supported care that truly improves patients' health. Participating organizations in the model will receive predictable payments for helping patients manage qualifying chronic conditions, and they'll earn the full amount when that patient meets measurable health goals relative to where they started, a reduction in their blood pressure, an improvement in their pain symptoms. It offers payment clarity alongside outcome accountability, and then gives clinicians the flexibility that they need in order to determine how best to deliver that care. So we're not micromanaging the practice of medicine, but rather we're communicating what we expect to see and giving flexibility around how that can best be achieved, including through the use of effective technologies. It focuses on conditions that affect more than 2/3 of people with Medicare. So this is not a small swing. Organizations can enroll a patient into a track which groups related conditions that have similar types and level of care, which really supports integrated patient-centered care. They're then responsible for capturing the baseline measure for the conditions in that track. What is their starting blood pressure? What is their starting weight? And then supporting patients to achieve improvement or control relative to where they started. Care delivery flexibility is a core part of the model. Clinicians have greater flexibility in how they deliver care without the typical constraints of activity-based reimbursement. That can be virtual, it can be asynchronous, it can be in person, really whatever works best in order to drive those outcomes. And also organizations will have the option to set a policy to either collect or forego the beneficiary cost sharing, which can often be a barrier to access. With the model, we wanted to make sure that we were removing the barriers that hold back innovation, but that we were reinforcing the parts that are working. And with that in mind, organizations that participate in Access must enroll in Medicare Part B as a provider or supplier, comply with licensure standards, data privacy and security as a HIPAA-covered entity, FDA requirements as appropriate, which we'll hear about shortly. They also must designate a physician clinical director who's responsible for clinical oversight and compliance, and CMS, based on the approach of the model, will be monitoring and measuring outcomes to also expose that so that people can understand risk-adjusted outcomes and really reward true clinical excellence. Another core part of the model isn't just enabling new ways of delivering care, but it's ensuring that that naturally complements and extends the traditional care delivery system. With that in mind, primary care physicians, referring clinicians, can refer to any of these access organizations because ultimately these are Medicare enrolled providers. There's no need for complex one-to-one contracting, which has often been a challenge to scale. Access organizations, for their part, are responsible for sharing proactively updates with the primary care physician, with the referring PCP, so that they are kept in the loop and able to truly coordinate care. We recognize, though, that it's important to get paid. And if you are that referring clinician, if you are that primary care physician, we're introducing a new co-management payment without beneficiary cost sharing that can be billed for documented review of the care plan and an associated care coordination activity. Finally, to help patients, clinicians make informed choices about where to seek out care, we'll be maintaining a directory of all access participants, including the conditions they treat and their risk-adjusted outcomes. And our hope is that the access really empowers every PCP, every clinician, with new tools in their toolkit, with new high-value referral partners to ultimately better support their patients. Another element of the model is that it really puts prevention at its center. By rewarding improvement or control on the leading indicators of disease, blood pressure, weight, A1C, cholesterol, we can reward organizations for keeping people healthy. I often think, in many ways, we know how to avoid most disease that will occur 10 years from now if we only had a better way of supporting patients in preventing the elevated blood pressure, their weight. To date, we haven't really enabled that. With Access Model, hopefully will, and a lot of disease that would have otherwise happened won't be seen tomorrow. The model is really scaled for system-wide impact. It uses standard billing infrastructure so that organizations in general, other payers can sign on to it. We'll be making an announcement about that shortly. We also anticipate that the Access Model will nurture a really robust ecosystem of technology-enabled care, both organizations as well as the supporting tooling that enables that. Amy spoke to some of that with health tech ecosystem, and then adjacent pieces as well, whether that's AI diagnostics that can help identify who are the patients who can benefit from these new solutions, connected devices, software that can streamline key workflows. And finally, outcome-aligned payments align payers, providers, and patients around what really matters most, which is innovation that truly delivers better health at an affordable cost. Speaking of alignment, we're thrilled that in very short order, we've been able to align so much of the ecosystem around this new approach and this model. The country's leading societies from across specialties, primary care, representing millions of patients, hundreds of thousands of clinicians, have signed on to a statement of support for the model. Many are also putting out statements of their own. I also think it's sort of unique that on the same slide in a short period of time, we were able to pull together not just the leading societies, but also the payer consortiums, who all believe that this new outcome-aligned payment approach can help us break free of the zero-sum competition or tension that has lived for so long in the fee-for-service world and can orient around a new option that truly rewards better care. We also have, on the value-based care side, NACOS on the ACO front. The next slide, on the participant front, we've been blown away that in just 2.5 days by the interest that we've seen, and this is only a small part of it. Over 250 of the leading technology-enabled care organizations submitted their intent to apply to the model, and we anticipate that this will grow significantly with new organizations over the course of the 10 years of this model. Finally, some details or logistics. Key dates to keep in mind. We will be releasing the request for applications very shortly. It's a dense document, but I think people in this room and tuning in virtually will be interested in those details. The application window will open in January, and the model itself will begin in July, serving patients. To begin in July, the application deadline will be April 1st, and the model has rolling admissions because we do anticipate that this is a long-standing initiative that will truly grow as the ecosystem around it grows. Speaking of alignment and collaboration, we're thrilled to have with us leaders from clinical societies, which is such a core part of the success of this model. It's my pleasure to introduce the leaders from the American Medical Association, American College of Cardiology, and American Psychiatric Association, alongside my colleague, Dr. Will Gordon, who will speak to the opportunities that they see with technology-supported care and the access model. With that, please join me in welcoming them onto the stage.
Just checking. Dr. White is backstage. He's coming in a second. It's poor timing for a consult. Well, good morning, everyone, and thank you for joining us for this conversation celebrating the launch of the Access Model. We've heard today about the opportunity the Access Model creates to realign healthcare delivery around outcomes. Now we want to shift to real-world implications, how access could change care delivery, and what that might mean for patients living with chronic conditions. Today, I'm joined by three extraordinary leaders representing the American Medical Association, the American College of Cardiology, and the American Psychiatric Association. Each brings a unique perspective on the opportunities and challenges facing patients and clinicians as we transition towards high-quality, high-value clinical care. My name is William Gordon. I'm a senior advisor at CMS for Technology and the chief informatics officer at the Innovation Center. I'm an internal medicine physician and see patients on the inpatient medical service at Brigham and Women's Hospital in Boston. I'm joined today by Dr. Ami Bhatt. Dr. Bhatt is the chief innovation officer of the American College of Cardiology. She's a cardiologist and a national leader in digital health and AI-enabled clinical care. She has 20 years of experience as a clinician, investigator, and educator with extensive experience in telemedicine and digital health as an associate professor of medicine at Harvard Medical School, where she served as the director of outpatient cardiology, telecardiology, and adult congenital heart disease at the Massachusetts General Hospital. Of note, Dr. Bhatt is also the chair of the FDA Digital Health Advisory Committee and recently led a multi-stakeholder meeting focused on AI-enabled digital mental health devices. Very much worth watching if you haven't already. Dr. Trustman is a professor and chair of psychiatry and behavioral medicine at the Virginia Tech Carilion School. I did look that up before coming here, and the Carilion School of Medicine and Carilion Clinic, and the national leader in behavioral healthcare delivery and policy. He serves as chair of the American Psychiatric Association's Council on Healthcare Systems and Financing, and as the APA's liaison to the American Hospital Association. Dr. Trustman previously spent over 2 decades at the University of Connecticut School of Medicine, where he was a tenured professor of medicine and psychiatry. A prolific researcher and co-developer of the Start Now psychotherapy model, he has authored more than 180 publications and edited the award-winning Oxford textbook of correctional psychiatry. And finally, Dr. John White. Dr. White is the Chief Executive Officer and Executive Vice President of the American Medical Association, the nation's largest physician organization. A nationally recognized leader in healthcare delivery policy and digital innovation, Dr. White previously served as the Chief Medical Officer at WebMD, and prior to WebMD, he served as Director of Professional Affairs and Stakeholder Engagement at the Center for Drug Evaluation and Research at FDA, and then previously had senior roles at CMS where he shaped U.S. healthcare policy. He's a board-certified internist and a prolific writer and communicator, and has written extensively in the medical and lay press, including 4 best-selling books. All right, let's jump in. So let's first ground ourselves in the problem that patients and clinicians are facing today. And we hear this across every specialty, the growing complexity of clinical practice. Clinicians are managing more comorbidities, more medications, more data streams, more technology, more expectations, more in-basket messages, often without more time. But simultaneously, we are in a crisis of chronic disease. More and more Americans are dealing with chronic diseases and need continuous support, but are faced with an overburdened and overstretched healthcare system. Chronic disease burden, rising patient complexity, and clinician burnout continue to strain the system. So Dr. White, let's start with you. With your broad perspective across specialties, what themes are you hearing most consistently about burden and the difficulty of practicing top of license?
And thank you for including us. And I think you summarized it well about the burden. And we often talk about the administrative burden, the paperwork that's required. But the other element that I think is important here is the amount of data that physicians have to deal with. And it's not about more data, it's about better data. And that's what I think we're talking about today. How do we have more continuous data? How do we have personalized data? How do we have data that knows it's going to improve outcomes? That's what clinicians are interested in, and that's what they'll be talking about. It's the acuity of the patients, as you commented, that are sicker today. We have less time to spend with each patient. The data that they currently may be collecting is still issues of interoperability. And then there's measures that you wonder, why are you doing if they're really impacting clinical care? So I think this is addressing some of those issues and acknowledging what physicians need to provide better care to patients.
Fantastic. Dr. Trussman, according to Mental Health America, here in the audience, almost a quarter of adults in the US experienced a mental illness in the past year. More than half did not receive treatment. We know access challenges in mental and behavioral health remain substantial. What pain points are your members seeing?
Our clinicians, our physicians are seeing substantial challenges as they have been. There's been a perfect storm of an improvement in people being willing to come forward to talk about psychiatric illness, particularly depression and anxiety, at a time when there are relatively few access points. There are relatively few, way too few psychiatrists now, and the projection is that there are going to be relatively fewer of us in the years ahead. So the challenge is, in limited time, how do we access our patients? How do we support them? And very, very few of our patients present with only a psychiatric condition. The vast majority of our Medicare patients have co-occurring cardiac conditions, metabolic conditions, orthopedic conditions. Chronic pain is a profound issue. So the complexity and the access to coordinated care is a critical issue. So those are all of the pain points. And I have to agree, the administrative burdens are significant, but the more profound challenges are really the support for decision making. And our role as physicians, we don't control people's lives, they do. We are the experts who are intended to provide the necessary information to help our patients make decisions and empower them in their lives. So improved coordination of care and access to all of the integrated care and coordinating among ourselves is critical and lacking in the current system.
I think fantastic. Well, not fantastic, but great points. Dr. Bott, where are you already seeing new care models or technologies make a real difference for clinicians or patients? What's actually working today?
Yeah, it's a great question. Thank you for having all of us, by the way. This is a great program, and we're excited for it. Cardiovascular disease, #1 killer of Americans, period. Also turns out, largely, almost fully preventable. And when we think about how, it's the cardiovascular risk factor. So I'll do 3 examples. One technology that's been really great has been the ability to actually measure blood pressure in the community where you live. It sounds like a simple thing, but everybody here who's older than me, you can guess how old that is, 1 out of 2 of you actually have high blood pressure. And we don't address it appropriately. It's an epidemic. And so importantly, being able to measure blood pressure in your home where you live, have that information sent back, managed by somebody in the clinical universe, not necessarily your primary care physician only, somebody, and then get information back to you still in the community where you live at home is important. And we have programs that do that. If you think about chronic disease care, it's a pyramid. The majority of people live in the bottom of the pyramid. I have chronic disease, hypertension, something else, and I'm managing it on my own at home. Then we have rising risk. So now the systems that we see for hypertension management tell us not only are you at your baseline, notice the word your baseline, personalized. Not all of us have the same baseline blood pressure. Not only are you at your baseline, but hey, you are now out of range and we should do something, and then we correct you where you live. Problem is these things don't scale. Largely they don't scale because of technology and payment. And so today is an exciting day for programs like that. So that's the first and I think most important one, which is the preventative measures that we can do like hypertension. The second, I just want to address generative AI. How many people here have used ChatGPT or Gemini or something? Right, okay. Keep your hand up if you've used it for healthcare. Just admit it, come on, okay. Ideally not your patients, maybe yourself. Don't put real data in there, okay. But generative AI, important, because now we're seeing generative AI specific for medicine. These models have trusted information about healthcare that for now, clinicians can use, ideally, eventually patients can use. And so I think that's going to be a real movement that's already starting, because guideline-directed medical therapy is out there, but majority of people in any field aren't receiving it. And so how do you get better care to the patients? You educate the people in the community, you educate the patients, and you increase the workforce by not just relying on the Harvard cardiologist, but relying on the people in the community caring for patients. And that means all of us as caregivers. So I think that's the second. And then the third, I don't want to leave old things alone, because I started here, and I think many people started in telemedicine. It's really important to be able to stay in your community and still be able to access care. And so telemedicine kind of can't be underemphasized. I'll tell one quick story. One of the first times I used telemedicine in 2013, I had a 40-year-old patient, third heart surgery that he needed. And I was going to bring him into the office, and I was going to hold his hand and tell him he needed a third heart surgery, and he refused. He made me do it over virtual medicine. And when we finished, he looked me right in the eye in the camera after his wife had left the room and said, "Thank you." And I was like, "Why are you thanking me? This is your third surgery." He said, "No, thank you for letting me be in my home with my family. This was the only way I was going to have a third surgery. You needed me to be with you. I needed to be here." And so I think we can't let telemedicine go as one of the successful examples.
Yeah, Dr. White, Dr. Schwarzman, Dr. White, are you seeing similar things? The opportunity, things that are actually starting to emerge today?
Absolutely. And I think part of it is on the patient side. Patients are very interested in utilizing these tools, determining how they can participate in their care. Because part of the challenges, and we've all discussed this, is there's a shortage of physicians, there's a shortage of nurses, a shortage of pharmacists. So what roles do these play? It's easy to say, well, you have to go see your physician. Everyone can't wait 6 months to see a physician. And I think the point about telehealth is very appropriate for here, that the reason why we saw all the increase in telehealth is because there was payment parity. Address the issue of licensure in the states. We made it available so physicians and others can be paid for the work that they do. We have to be realistic. That's relevant. People aren't going to do necessarily what they're not paid for, but it was also leading to better outcomes. And I think what we're learning now about telehealth is really determining what's the standard of care, and then determining whether it has to be virtual or in person, or it can be either. And those are the ways that we should look at things. Does it meet the standard? And then does the way that you do it really matter? So I think that's what's exciting about this model, but also we're learning from the past. And I think telehealth is a good example of that.
Yeah. Sure.
So telehealth cannot be underestimated. It's now old school, right? But the reality is, particularly for many of us who practice in rural America, it's the only way we're going to be able to leverage our limited abilities to meet the needs of our patients. So couple that with enhancements that allow access to accurate diagnostic capabilities in real time at the point of care. Link that. Now what we're doing is measurement-informed care more and more. And we're doing that in collaboration with primary care asynchronously now with e-consults. We're doing it in collaborative care models that have leveraged amazingly our ability to support primary care, and doing it in a meaningful way that overcomes a lot of the obstacles of transportation. And as we're doing it, we're getting better at it. But the integration of all of these cannot be overemphasized. The need for that, without having to sign out of one document, sign into something else, get access to this. For us to make a difference in the lives of our patients, more and more, we're seeing the need for it to be available quickly and to be able to be outcome focused, which is a wonderful part of this model.
Yeah, and it's a great point, and actually a great segue, because I think another major theme that we're seeing here across the various actors in the healthcare delivery space is shifting more towards outcomes away from activities. And so we heard about outcome-aligned payments today. For example, better control of chronic disease, fewer hospitalizations, improved patient experience. I'd love to hear how your organizations are thinking about this transition and what resonates the most about outcome-based payments. And Dr. Schwartzman, I'll start with you. I think behavioral health does present a particularly unique challenge. Outcomes are more subjective, they're longitudinal, they're harder to capture. Are we measuring the things that truly matter?
I think we have a long way to go, ideally, as we are seeking underlying neurobiologic parallels to hemoglobin A1C or to blood pressure. Nevertheless, we have the basic tools we need, whether it is a patient health questionnaire, PHQ-9, or a generalized anxiety disorder questionnaire, GAD-7. Those simple tools that are already in widespread use, if used consistently, make a difference. These have been published studies repeatedly demonstrating that we engage patients in their own evaluation, getting their input, we can make a difference. And they can see it. It's not, this is the worst day of my life, doc, sort of thing. It's not the traditional subjective information. The objective data may not be yet perfect, but it is far superior to anything else. And I've seen with my own patients, when their depression scores drop and they see the trend line, it makes a difference. They feel proud. They feel empowered. And this is part of what we're working to do, to integrate that seamlessly into care delivery.
Yeah. And Dr. Bott, you kind of alluded to this. I think the cardiometabolic space does not suffer from a lack of biomarker outcomes. LDL, A1C, blood pressure, weight, these have been established for decades at this point as well-validated primary and secondary outcome measures. Where do you see the greatest opportunity for capturing outcomes?
I think, and I'll give a call out to my team, my CEO, Kathy Gates, and James Vavracek, head of health policy, are here. And they've been working in rural America, really thinking about who are the people who need cardiovascular care, cardiovascular preventive care the most. And so I would say, yes, we have a lot of metrics, but the problem is, and we face this a lot, we try to offer gold standard care. Is gold standard care better than no care at all? And there are areas of this country that just don't have access and don't receive care. And so when you get there, you can say, I have all these metrics I can measure. Actually, no, I can't measure them. They don't have the capacity to measure, to keep record of these, to be able to know what your patient's baseline is and when they're off baseline, like we were talking about before. And so I think the payment outcome part is so important, and aligning those two, because now we are actually going to create a mechanism to say I'm capturing data in the areas from which I was not getting data before. And so for the individual, you have a personalized response, yes, but also for the community, now people like us at the ACC and other organizations can help direct our efforts to those communities better, because we're doing it based on knowledge of how that actual community is responding to the efforts that we're putting in there. And so I think that's really essential, is we have to think about the areas that have zero access right now. And yes, we could collect data, but we're not doing it. And so what are the systems that we put in place? And if you don't pay up front for that, you can't do it. I think that's something that we forget. Hey, there's a payment code for it. Well, there may be, but I can't actually get this digital health mechanism, this data capturing mechanism into my hospital system because I'm running on like net zero margin or worse. And so I think that's really important, is that access is coming because payment is coming.
Yeah. Right. And Dr. White, one thing we often hear, a common expression, you can't improve what you don't measure. Yet I think it's not controversial to say clinicians are exhausted by measurement at the same time. How do we strike the right balance?
Yeah, and I think this goes to the point that when you're going to hold clinicians and others accountable for outcomes, they have to be able to impact those outcomes. And I think all too often, a lot of clinicians are seeing there's just more and more outcomes. And I can say this from my own time in clinical practice, where now I have to do a food insecurity assessment. Can I really impact that? Not that it's not important, but as a physician, I may not be the best person to have influence over that. So it goes back to the point, we need to have better data, maybe less data in a way, for which we can actually impact. I love the point about there's a lot of metrics. Yes, there are, and I can't impact all of them. Measure me by what I can impact and hold me accountable for that. I think that's what clinicians are interested in having the conversation around.
Yeah. All right, so flash round. What's one outcome, clinical, patient-reported, or other, that you wish you had better tools to capture? I'll start, well, if you're ready. Yeah.
I think the one thing is transforming the data into useful information and having it presented in an integrated way so that clinicians in real time at the point of care can help to support decision-making then.
I mean, I may take a more tactical approach even when we talk about making America healthy again, what's going to have impact. We all know the value of sleep. We don't really measure sleep. We don't talk about sleep. I learned a couple years ago, someone said to me, if you really want to know how someone is feeling, you don't do the perfunctory in the office, how are you? Fine, how are you? You say, how did you sleep last night? How did you sleep last night? People will tell you the truth about it. And what I think is interesting about what we're talking about today in tech-enabled care, we have tools that can measure sleep. Some of them can measure sleep apnea. Are they ready for prime time yet? I'm not sure, but they're going to get better. And here's the perfect example. Am I going to believe in the fidelity of the data from a wearable about sleep? And if I do, can I get reimbursed for it? Is it going to feed into the medical record where it needs to feed into the medical record? Is it going to generate a report that insurance is going to accept? This is the type of outcome and discussion that we want to have to improve patients' health. So it's as you're talking about, it's the outcome, but then it's also the payment model as well.
Okay, I don't have a word for my thing. I'm going to try to describe it. It's not health literacy at the patient level, and it's not engagement, because we know that just using the blood pressure cuff isn't enough. So I don't have a word for what I'm thinking of, but I'll describe it, which is maybe like a net promoter score from a patient, and a patient saying, I feel like a partner in my care. Like, I feel like an equal partner in my health care. Whatever, if we could measure that, I think that would be incredible, because that's what we're aiming for. We're not aiming to do things to people, right? And we're not expecting people to figure out how to do it on their own. And so whatever that net promoter score of a patient saying, I feel like a partner in my care, I want that measure.
Yeah. Yep. Okay, so let's zoom out, and let's imagine we're back here a few years from now, save the date, and Access is successful. Maybe very briefly, what do you think will be different in the day-to-day lives of your members, and I think most importantly for the patients they care for? Maybe I'll start, Dr. Watt.
I can go first this time.
Yeah.
Our clinician members will get more time with the patients, and the patients will feel seen, whether they're at home or in the office, they'll feel seen. I think that's the future that we're aiming for.
Yeah. That's just
that our physicians feel empowered to support our patients and have the time that they need to make those decisions in a thoughtful way.
Dr. White?
I think we're going to shift care from the classic hospital setting to more of the ambulatory care setting and even the home setting. And that's not something that we truly have right now.
Great. Save the date a few years from now. So thank you to our panelists. Really, I think, tremendous insights in a dynamic discussion. I think what we heard is a very compelling story, and probably, again, not controversial. Patients need better access. Clinicians need relief and the ability to help patients. And that outcome online payments are exciting, but only with meaningful measures that are actually measurable and better data. So I think we really need to continue building toward this learning healthcare system where clinicians have the support and tools they need to deliver on this excellent care. So as we move forward, really the collaboration between CMS, professional societies, physicians, and patients will be essential. And so thank you again to our speakers, and thank you to everyone working to make care better for millions of Americans. Thank you.
Okay, I really enjoyed that. Next up, we recognize payment policy is one of the most important legs of the stool, but there is more that we need in order to truly unlock innovation. The other is regulation and ensuring that, as Deputy Secretary Jim O'Neill said earlier, we have the right amount of regulation that ensures safety and efficacy. With that, we have an exciting announcement from our colleagues at FDA. I'm thrilled to welcome one of the leaders at FDA, Jim Traficant. Jim serves as FDA Chief of Staff under Commissioner McCary. He has an extraordinary background as a technologist, entrepreneur, business executive. Couldn't ask for someone better to be speaking today. We're excited to have him speak this morning about the exciting collaboration between CMS and FDA related to the access model, as well as FDA's approach more generally. Thank you.
Hey, it's great to be with you. As Jacob said, I'm Jim Traficant with the Chief of Staff at the FDA, and I'm here on behalf of Commissioner McCary and also Dr. Michelle Tarver, who is the CDRH Director. She couldn't be here. They're both speaking in New York today. And it's a privilege for FDA to collaborate with CMS Innovation and to support the Access program being heralded here today. And it's also part of the FDA mission. And I love serving at the FDA. I've had 2 liver transplants, and in my first one, access to an experimental drug through FDA's compassionate use saved my life. And I never imagined I'd get a chance to serve at FDA out of gratitude for that gift. It's just amazing. Commissioner McCary is leveraging gold standard science and technology innovation to transform FDA into a collaborative enterprise. Everything we focus on is to drive better outcomes for patients and affordability for the American people. And under Dr. McCary's leadership, we're putting the F back in FDA, focusing on food, better food, and healthier food for our children, so that we're not paying for it years later in Medicare and Medicaid. We're accelerating cures and breakthrough therapies, enhancing our global competitiveness by streamlining regulatory processes, providing clarity to industry and better communication, and delivering on our promises, hitting our user fee agreements. And all of this is undergirded by better technology. It's kind of remarkable what's happening at the FDA. Historically, all the centers had their own IT. It was all different. And for those of you that have interacted where you've got a combination drug, you would have different applications going into different centers, and the centers didn't talk. That was then. It's not now. We're changing it. And it's kind of exciting, honestly, to be part of it. From a technology standpoint, we're modernizing with common data models, common platforms, common processes, and common sense. We're leveraging AI to streamline regulatory workflows, implementing shared services to drive out all that redundancy that I just described, and align our work across medical products, food, cosmetics, tobacco, and veterinary. In fact, earlier this week we announced we're recommending computational models over animal testing when we're dealing with monoclonal antibodies. All the data shows that AI is better, so let's use it. And all of this is part of our roadmap to leverage data and AI and reduce animal testing in drug development. And with regard to our pivot to shared services, I mentioned all the redundancy that was occurring within the centers. We consolidated all of that, and we're now delivering equivalent operational support that we had a year ago with less than half the staff. It's just a remarkable pivot. And we're also working across government to do even more for the American people. And it's rare in government. For those of you that have served in the federal sector, you'll appreciate this and probably recognize it already. It's why you're here. But to have alignment with the HHS secretary and you see the optives collaborating, it's so in uniform, flying in formation, if you will, that's extremely rare. Secretary Kennedy's leadership, it's a reality under this administration. You can see it with Dr. Oz, Dr. McCary, Dr. Bhattacharya, DepSec O'Neill, as he was describing our program even today. High degree of collaboration. It's a very unique time. And at FDA, CDRH's mission, that's our Center for Device and Radiological Health, our mission is to catalyze innovative, safe, effective, and high-quality medical devices. Most of you have been part of it. We regulate innovation within the parameters of safety and effectiveness, which are our guiding principles for helping emerging digital health devices ultimately benefit the American people with their health and wellness. And with the explosion of digital health technologies, we have a unique opportunity here to extend care to corners of the country that have historically gone without. Traditional healthcare is facing incredible challenges. A lot of it's been discussed already, but technology is foundational to addressing them. The American Medical Association estimates 35% of doctors are near retirement. And when we look at the medical schools, we've only got capacity to fill about 19% of that. So where's the rest of it going to come? Has to come with technology. On top of this, we're seeing more physicians opt for non-clinical career paths. Technology is key to bending the cost curve that you heard Dr. Oz speak to earlier. It's also key to improving health, affordability, and access to care. It's estimated more than 30 million people live in primary healthcare deserts. At the same time, we're hearing these chronic diseases just skyrocket. Jacob talked about it. You know, access is designed to address 2/3 of the population in Medicare. It's a big swing. And FDA is also innovating in partnership with CMS and across government, NIH included, to attack these challenges. We have a pilot we've created called Home as a Healthcare Hub. It reimagines how home as a setting for enhancing care, wellness, and prevention. And our goal is to accelerate access to quality care wherever you live in the country and to get rid of these primary care deserts. We envision a future where medical technologies, like we experience consumer technology, seamless, integrated, intuitive, and helping people readily prevent and manage chronic conditions at home. But our job in government is to turn vision into reality. Early input from regulators, providers, payers, patients are all essential to improving the journey from device concept to adoption. And to facilitate this even more, CDRH put in another innovative pilot called TAP, and it's for our Total Product Lifecycle Advisory Program. And it works really closely with breakthrough device developers in the cardiovascular, physical medicine, neurological, psychiatric, ophthalmic, orthopedic, and radiologic specialties. Really remarkable. And the goal is to provide timely input from the healthcare ecosystem to help these devices move quicker through the process to approval and bridge the gap between device approval and reimbursement, thus the partnership with CMS. And all of these innovative programs I just described are the undergirding for why we're here today. Today, FDA, in collaboration with CMS, is announcing a new pilot. You heard the Deputy Secretary O'Neill talk about it. It's called Tempo. Tempo is an acronym for Technology-Enabled Meaningful Patient Outcomes for Digital Health Devices. Tempo is an FDA initiative for manufacturers of certain digital health devices that desire to work within the CMS access system for an intended use that would typically require FDA pre-market authorization, but you haven't received that authorization, so now what do you do? But under the Tempo pilot, device manufacturers can request that FDA exercise enforcement discretion, and when their device is offered inside of the access model, you can get even an exemption from FDA pre-market authorization. Access participants may use a device consistent with any plan for mitigating risks to patients and collecting, monitoring, analyzing, and reporting real-world performance data that the manufacturer has discussed with FDA in connection with FDA's determination that it's appropriate to exercise enforcement discretion for the device under the Tempo pilot. So you can see CMS, we're coming together to make this happen. And with access participation, devices under the Tempo pilot will generate real-world data that may support assessment of safety, performance, and potential future FDA marketing approvals. And additional data collection beyond what is ordinarily reported within access can also be negotiated and may be provided to FDA as agreed upon with FDA. Of course, the pilot is optional, but it might be of particular value for companies developing certain digital health devices that would generally require this pre-market authorization. And by facilitating use of those devices in a controlled context, we can accelerate access to the market for these breakthrough therapies. And a couple of conditions, and we're going to learn more about this, and I'll just give you some ways to find out all the details. Access participants that choose to use a device in the Tempo pilot associated with access will need to obtain enhanced consent from enrolled beneficiaries, informing them that the device is participating in an FDA pilot, and that certain data will be shared with FDA consistent with all the applicable federal security and privacy standards. Ultimately, FDA Tempo, this pilot is a regulatory sandbox to facilitate digital health technologies that improve health outcomes. That's what we're about here at HHS and FDA. Manufacturers interested in Tempo should apply directly to FDA once the application process opens. You can expect that to be early next year. We'll be issuing a Federal Register notice soon with additional details regarding participation. So you'll want to look for that and then jump into the program. We hope you'll visit our website and become part of the FDA's Tempo for better health. Thanks.
Thank you very much. It's on the personal side, it's been a pleasure working with our colleagues at FDA, including Michelle Tarver, who couldn't be here today. And we're very excited about the Tempo initiative. All right, so we're wrapping up. Over the course of this morning, we've talked about some of the challenges that are facing the country: rampant chronic disease, rising costs, overstretched clinicians. We've also talked about what's possible. Technology is no longer the barrier. What has been the regulatory and payment piece. And today, we're very excited about what we've discussed: FDA's Tempo program, the CMS health tech ecosystem, and of course, the newly announced access model and its outcome-aligned payment option. It's our belief that there is a world of opportunity ahead for those in the room and those tuning in virtually, and we're very excited to see everyone participate and truly realize this potential to ultimately make innovation a driver of better health for millions of people. Thank you for coming.
Produced by the U.S. Department of Health and Human Services.